I'm curious, while we're on the topic, if we were in a world where we were doing something towards a more unified payment system like Medicare-for-All, what would that look like?
I think that the payment model would be straightforward. The hospitals would be in total chaos from that, because that would have been such a financial shock to go from, again, the commercially insured payments to public payments. So we wrote a paper last year, and I think I talked to Elisabeth about this at some point. So we looked at payment models for what Medicare-for-All could be, how we have this 33% of the market's commercially insured, and the health system charges them a much higher rate above their costs. And then we have the public programs that are charged a much lower rate. The data we used for that was the American Hospital Association data. And one of the visiting scholars at Stanford is a guy named Jack Rowe, who used to be the CEO of Aetna. And as soon as that paper got published, he called me and yelled at me. He said that was trade association data. That wasn't anywhere near what they were paying. They were paying much higher rates. And finally, last summer, I said, well, that's the best we had at the time. Well, last summer, RAND actually published the rates for self-insured employers. And for hospitals, we were paying 300 to 400% of Medicare, and for outpatient services, 400, 500, 600% of Medicare. So the cost shift is actually much greater than even what I had projected. We had described. It's in the same direction. But so hospitals would have been in a huge financial hole right now coming into the pandemic, just from that.
Yeah, and I'm going to be, since I have nothing to do with a hospital at the moment, somewhat, and I know Kevin is not totally sympathetic with that plight. I feel like hospitals, yes, if we came into the pandemic with a Medicare-for-All system, they would be in huge trouble, even more trouble than they're in now. You know, they are now getting, and I think this is really, speaks to this. They're now getting something like 100 billion in COVID relief funds. And why is that? It's because they so make their business out of doing these elective procedures that aren't happening now. So it's partly the cost of taking care of COVID, but I think, and Kevin maybe as an economist could say more about this, it's in very large part too the fact that they're cash cows they're not able to tap into right now. And I'm of limited sympathy with that, in that I think these were not great cash cows to begin with, and some of these elective procedures have historically been overused and abused because they are so lucrative. I do, as I go around and speak at hospitals, and I know Kevin and I agree on this too, I'll look around, and part of their dilemma right now is they've kind of had their heads in the sand about what was coming down the pike in terms of the rational future of medicine. So when I go to these hospitals, I was at UVA speaking last month, or not last month, before COVID, which is much longer than last month. They showed me their brand new $1 billion hospital. And I was like, to replace a pretty new, $500 million hospital that wasn't that old. And I'm like, wow, I hope you guys all, have plans to turn this into condos, because I don't think fancy inpatient care is really where our system needs to be heading. And so I think a lot of hospitals and our health system, in many ways, the problem is that it's hardwired to deliver a kind of health care that is not what we need. And the COVID outbreak has just kind of, opened the curtain on that in such a dramatic way.
Yeah, I mean, I think, one of the things, and especially from the business side, business managers make choices. And if you go back and look 20 years ago, we didn't see as much of a difference between the public and private payment models as we see. And we've allowed, at the market level, the consolidation of health systems is no secret. The reason why they consolidated was actually Moses Cone. It was a hospital in North Carolina that got acquired by Carolina's Healthcare, now called Atrium. And the president said, well, they got acquired because Carolinas had expertise in payer relationships and supply chain management. In other words, they knew how to raise premiums and reduce costs on things that, purchasing like PPEs. And so we've built this over a 20-year period, this model, as healthcare costs have increased by 155%. We've built a model that was really, escalating costs year after year, and following close behind our ability to get higher and higher commercial payments was our ability or our interest in actually building property, plant, and equipment that catered to that market. So when I was at Duke, we would round at the VA, which is publicly funded. Most cancer patients are Medicare beneficiaries. That's publicly funded. And I would ask my residents a rhetorical question: why is it that the VA looks like it does, built in 1950, and our cancer center has this amazingly elegant fireplace in the, in the atrium? Why? They're both publicly funded programs. Why do they look so different? And I think we have to start asking really hard questions. Do we really want to bail out poor choices of managers? It's almost as like the financial crisis. If instead of investing in property, plant, and equipment, hospital leaders had invested in derivatives, would you want to bail them out for that? And if we do bail them out, what do we get in return? Do we go back to ever increasing, escalating costs to private health insurance? Or do we have some other pathway to a different model where they're going to have to be accountable for the cost of care? It kind of begs back to Libby's Kaiser's data from their employer survey. Employer and employees were paying $20,000 last year for private health insurance. The United States is paying 18% of GDP in the old days, pre-COVID, for healthcare, versus the next highest, most expensive was Switzerland at around 12%. So we're paying almost 6% more in GDP in healthcare, and there's no measurable improvement in health outcomes. And we know our public health system is measurably deficient compared to some of those other countries.